Today, inshallah, I'll be explaining chest pain. Case 2, these are the learning goals that we will go through. We'll talk a little bit about the topography of the coronary arteries, the ischemic heart diseases, the pathogenesis of myocardial infarction. We will see the difference between the subendocardial and transmural infarction. We will talk a little bit about the ECG and what are the main abnormalities in it. We will see the cardiac biomarkers interpretation and the timing where after the MI will start, what are the biomarkers that can indicate that we have an infarction. We will see early and late histological changes, healing and remodeling, and then the gender differences in the MI. Starting off, first of all, with the topography of the coronary arteries. As you can see here, you have the anterior view. Here you got the trunk of the aorta. So basically here where it will branch, which they are the right coronary artery and the left coronary artery. So there is something that I want to assess on that normally in systole, when the patient, when the left ventricle, it will contract, all the body will get the blood. Okay, this is a normal state. But the heart itself, it has its own coronary arteries to supply it. So the heart will get the supply of the blood when the diastole. So look here, when we got the bad mycephalic contraction in the heart, okay, so the blood will leave, and after that the semilunar valve will be closed. So when the blood will try to come back, those semilunar valve, they will contract, and the blood will lead to go to the two coronary arteries. So if a question comes when the heart will be supplied by its own blood, it's doing the diastole, unlike the other organs which the heart will supply. Here we have the right coronary artery and the left coronary artery. So right coronary artery, it will give branches as well, which they are the marginal artery. Here, it's a branch in the margins, and it also will go to the back. And also it has another important branch, which is the posterior interverticular branch within the posterior interverticular groove. A very important point to notice that you have to know which artery supplies which part of the heart. So when we say posterior interverticular branch, so the posterior side with both the ventricles will be supplied by this artery. Here, the right marginal branch will supply the lateral or the margin of the right ventricle. Now, here, the left coronary artery, it will also have two branches. We have the circumflex branch of the left coronary artery, which it will supply the circumflex. And we got the also left marginal artery, which will go to the back and supply the back left of the heart. And also we have the very important one, which is the anterior interventricular branch, which is, we call it the LAD, or left anterior descending artery, which will supply also the anterior two ventricles. Here also you can see from the back the circumflex branch, and I think the second one here we can see. So it's important for you to try to enumerate the right coronary artery or left coronary artery, what it supplies. So the right coronary artery will supply the right atrium here, and most of the right ventricle as well, part of the left ventricle, which is in the below in the diaphragmatic surface, the part of the septum, or the usually the posterior third, and we have the SA node and the AV node. Okay, and the left coronary artery, left atrium, most of the left ventricle, part of the right ventricles, the AD bundle as well, the IV septal as well, and the SA node just only in 40%. So mostly the SA node is supplied by the right coronary artery. Now here a question comes that what is the collateral circulation and what is the significance of it? Now basically the collateral circulation, they are the blood vessels, they are present, okay? And they work as a backup in your body that can take over when another artery or vein that becomes blocked or damaged. So usually يعني, they have a blood in them, but like يعني, they are not well supplied. But when they are over supplying or overworked, when one of the vessels will get blocked, so they will get over. So what are their benefits? They limit the infarct size. يعني لما نيجي نتكلم عن المyocardial infarction, we see that لأن الانفاركشن it will يعني when it first start يعني the heart it will not die immediately. So those collateral arteries they try to reduce the risk of the death of the myocardium. So they will prevent also the transmural infarction. We will talk about the transmural, which means the whole tissue of the heart. It will give death. It will maintain the myocardial function. It will try to keep making the work of the heart, which is the contraction, relaxation, to keep working, improve prognosis after revascularization. Okay. So let's start with the ischemic heart diseases. So what do we mean by the ischemic heart diseases? They are basically syndrome relating to the myocardial ischemia. Ischemic heart disease, it means يعني mainly we have less supply of oxygen to the heart due to any reason, due to any disease. We put it under the type of ischemic heart diseases. So we got some syndrome, which myocardial infarction, angina pectoris, chronic ischemic heart disease, and sudden cardiac death. What are the consequences of myocardial ischemia? When we have a block or when we have less oxygen of the heart or myocardium, what are the consequences? We have multiple options to get. First of all, we got the stable angina. Stable angina, it's basically due to increased myocardial oxygen demand with the blood disruption, which means the heart will need the oxygen. Okay, but still the block or البلاك اللي انتجت or it's formed, it's not fully disrupted or ما صار لها شرخ يخليها مثلا blood to occlude the whole human. The artery is still able to give some blood to the organs. Okay, it is still safe. Unstable angina caused by blood disruption that result in thrombosis and vasoconstriction leading to transient ischemia. So we got either thrombosis or vasoconstriction, which is it increase the risk or dangers of the death of the cardiac tissue. We myocardial infarction, that's the death. And then other option can be sudden cardiac death, like without going into so much process. Okay. So let's see the pathogenesis of the ischemic heart diseases. As you can see, here we have the layers of the lumen or of the blood vessels. We got the intima, the media, the adventitia, which has the vessels, the media, which has اللي هو المسل tissue, and هاي the intima. So atherosclerosis, when it occurs, this is one of the reasons of the ischemic heart disease. It occurs in the intima. Okay, so you will see that we call it atherosclerotic block. It will be formed of cholesterol, of other molecules that can be concentrated. So the risk factors of it can be increased cholesterol levels in the blood or hypertension, which leads to vasoconstriction. Diabetes also can be one of the risk factors for the occurring of the atherosclerosis, and aging. So much factors can lead to this risk. After that, we have the platelet aggregates. So here the fibrous cap we call it, which is الكاب اللي في داخلها اليومن اللي فيه الكوليسترول. Atherosclerotic lipid core, increased inflammation, hypertension, as I said, and vasoconstriction. This is all will lead to either fixed coronary obstruction fixed. So الكاب لسه closed ما فتحت. If it was less than 70% luminal obstruction, we call it asymptomatic. So the patient, in this case, will not have nausea, will not have tiredness. So you will feel that this is normal, or let's say it's silent, okay? Because still the heart or the blood vessels, they are able to function. When it exceeds the 70%, but it's still closed, as I said, we got symptoms only on exertion. So it's more than 70%, but it's less than 90%. So when the patient, for example, walks or do any activity, he will start to have some symptoms, or he will have an angina pectoris, for example, a pain. He said that I have a chest pain. When it's severe fixed coronary obstruction, for example, more than 90%, this is where we call the chronic ischemia heart disease. This is where it's يعني symptoms he will experience even when rest, even when he's sitting, he will have some symptoms. طيب, here when the blood has disrupted, it's either neurothrombosis with variable obstruction, which means we call it subendocardial myocardial infarction. يعني it's not all the cardium has been affected, just sub with it, but it can lead to a sudden death. Here, the acute transmural, which is all, as you can see, all the lumen has been occluded. طيب, I mentioned angina pectoris, which is a chest pain, substernal side. We can say it's a discomfort and caused by transient reversible myocardial ischemia. So it comes and goes. What are the characteristics of it? It starts from to 15 minutes, but it's not severe to say it will cause the myocyte necrosis. So why the patient will feel the pain? It's due to release of some molecules, the adenosine, bradykinin, and other molecules that stimulate the sympathetics and vagal nerve afferent. That we know إنه البين pathway in our body, it will يعني lead to increase of substances. Those substances اللي هم مثل adenosine or bradykinin, those will make us feel the pain. Okay. So, and this angina pectoris, it's increased by any the activity the patient will do, and also of going into high areas, also by making any kind of activity. And here are the types of the angina pectoris. So we have a stable, which will depend on the myocardial demand. It's poorly localized pressure, so it's like a burning sensation, but it's still it's not so severe. You can treat it by administering of some vasodilators such as nitroglycerin. So the unstable or the crescendo, it's more than 20 minutes. So here we say the stable one, it's usually from 15 seconds to 15 minutes, but here it exceeds the 20 minutes frequent severe angina and chest pain. It's basically precipitated by lower levels of physical activity or even at rest. So here we said the patient is exaggerated, he's doing so much work or exerting on himself. Here it's even by resting. Now, Brinzimental variant is caused coronary artery spasm. This is it's way different from the others. It's unrelated to myocardial demand. It's not related to the oxygen demand of the heart, and you can treat it, or if it's not too late to treat it, by administration of some vasodilators. Here you can see that the normal coronary artery here with the atherosclerosis, and the block will start to form, how it will narrow the lumen, and here when there is a rupture. Now here we have three types. Let's try to talk about them. Silent myocardial ischemia, it's a condition when the myocardial blood flow is reduced, but even it's called silent because the normal symptoms or discomfort that the patient will feel, he's not able to feel due to any reason. So we call it silent myocardial ischemia. Coronary steal syndrome, this basically occurs when stenosis will cause the vessels basically to dilate. This is unusual. So when you come to treat the patient, you will give him vasodilators such as dipyrmidol or rigandozone. So this dilators, when administered into the vessels, you will see that already the diseased vessels, they are dilated. So this dilator will go to the normal vessels, okay? So what will happen is that the body will try to control by giving a blood shunt to the dilated normal vessels. يعني الأوعية الطبيعية عند الإنسان هي صار لها dilation. ليش؟ لأنه الديزيزد one it's already dilated. فاللي صار إنه الجسم بيحاول يعمل ميكانيزم يعطي more blood to the normal one. ليش؟ لأنه صار لها dilation. So this is will worsen the the vessels that they are injured because they are not having a blood, and the body, when it tries to compensate, it's not giving it blood. So this is why it's called coronary steal syndrome. So the diseased ones, they haven't got the treatment, but the normal one, they have got it. Now, the third type is the sudden cardiac death. It occurs within 1 hour of the symptoms, mostly due to arrhythmia, as ventricular fibrillation, or cardiomyopathy, or any type of hereditary disease. Okay, so here also another ischemic for the coronary thrombus. So we have small thrombus, we got partially, and we got occlusive thrombus. So small thrombus, you will see that there is no ECG changes, and uh, here in the partially occlusive thrombus, you get the ST segment in the ECG. It's the breast, or the T wave has inverted. So when it's unstable angina, so we don't have a still myocardial infarction, we can't see any serum biomarkers. We will talk about the serum biomarkers that occurred after the myocardial infarction. But here in the non-STEMI elevation after the ST has been elevated after the myocardial infarction, we see that the biomarkers will start to appear. And here, when we have an occlusive of the thrombus, the ST has been elevated, and the Q wave also it will appear. And of course يعني ال ST اللي هو segment from S to T, it has been elevated. طيب after the ischemic heart disease it has started, so either it's reversible and the patient has healed itself due يعني خلاص he made a surgery or he took a vasodilator and it works, or it can lead to a myocardial infarction. So what's the myocardial infarction? Infarction, it means death, okay, of the heart muscle, which is the myocardium. It can be caused by ischemia, which is, I said, the lack of oxygen delivery. It's a type of acute coronary syndrome, which a sudden or short-term change in the symptoms related to blood flow to the heart. Type. What are the symptoms that the patient can have when after the MI? Chest pain or angina pectoris. It can spread to the left shoulder or to the left jaw. Abdomen pain, shortness of breath, sweating or breath freezing, nausea, palpitations, fainting. So here when we want to differentiate between the symptoms between men and women, we will see that the old women, they have atypical symptoms, which means 30% of them, they have no pain, and only 20% they have mild or symptoms. We call it vague pain. It's either due because they have a diabetes. This is why the pain is hidden, or the pathway of pain that I told you about, it's not appearing for those patients. We know the diabetes can cause hiding of the symptoms. Neuro pathway is not working or non-functioning. And the causes of the myocardial infarction can be, as we said, due to thrombus that in the artery, or there is an embolism. When you come to talk in the valves diseases, you will see that some embolisms can occur, and this can also lead to myocardial infarction, mitral stenosis or aortic stenosis, endocarditis, coronary spasm due to cocaine use, or coronary artery dissection. So these are some of the causes. And the risk factors, of course, we got aging, we got diabetes, as we said, we have hypertension because it leads to vasoconstriction. We have high cholesterol, which is very important risk factors for the occurrence of the atherosclerosis. We have smoking. Also, smoking can lead to vasoconstriction, psychosocial stress, and unhealthy diets because it leads to the buildup of cholesterol, obesity, also the fats increase in the body, also sedentary lifestyle, so without physical work, and family history. So if the family also has the gene of heart disease, so it can be spread for the other generations. Now let's see the pathogenesis of the formation of the block or the myocardial infarction. So a coronary artery thrombus block undergoes acute changes like hemorrhage, erosion, ulceration, rupture, or fissuring. So the block itself, it's not stable, Okay, the block here it's not stable, so it will be eroded. The blood will comes out. When the thrombogenic subendothelial collagen and blood content become exposed, يعني لما البلد يطلع, the body will interpret this as as any injury. يعني the body will say that this is injury, and normally when we have injury in our body, the body will try to heal it. So it will send platelets to platelets and then release granules content and aggregate formation of microthrombi. يعني مثل أي جرح عادي بالجسم, the body will try to bring platelets, it will bring neutrophils, it will bring macrophages, it will try to heal and close this injury. Now, the platelets, it will read medullatus that cause vasospasm, more vasoconstriction to close this injury. The coagulation pathway gets activated by the tissue factor, increasing the thrombus site. So, يعني, when this tissue it has been closed or coagulated, you will see that the scar it will start to increase in size, and the thrombus expand and completely occlude the vessel lumen. So this is why the myocardial infarction, it will start by healing a process, but it will lead to the death. Okay, so here as a summary, so acute changing of the blood, platelet adhesion and aggregation, vasospasm and coagulative pathway, and thrombosis expansion. Now there is something I want to assess on, that the type of the infarct in the heart, it's called coagulative infarction. Why it's called coagulative? Because in some solid organs, such as the heart, the type of the scar or يعني the type of the death is still consume the shape. يعني the heart is still keeping its shape even when it's infarcted, even when the cell is death, it still have this the shape has been maintained. Okay, this is why we call it coagulative infarction. Now, to differentiate between the transmural and subendocardial infarct, the one that we have already mentioned both, here, I believe that we said that we have subendocardial and the transmural. So, what are the main differences? Transmural, or let's start by here, subendocardial. We have non-STEMI elevation, most valuable inner third of the ventricular wall, only the inner third. So, as you can see here, only a part, which is death, not all of the tissue, and hypotension or thrombus that it has been formed. But here in the transmural STEMI occlusion, when we have an ST segment elevation, the fall of the ventricular has been dead. Okay, as you can see, this whole segment. Okay. Okay, let's move on to the ECG. So you have learned that this is a recording of the impulse of the heart. It's showing you how the rhythm going on. Is it like a normal rhythm, or is the patient is experiencing tachycardia or bradycardia or ventricular fibrillation, any type of diseases? It's showing you also the timing of the electrical impulses, how they move, and the different parts in the different parts of the heart. So any change in the ECG can be a sign of many heart-related conditions. So when we talk about the myocardial infarction, we can say that changes in the ECG, it can be a sign of an infarct. So I think that you have studied what the P wave, it will indicate the atrial depolarization, and then the QRS, which will indicate the ventricular depolarization, and also the QRS, it will contain the atrial repolarization because it's lesser or smaller than the ventricular effect. This is why it's hidden. So we say the QRS, it's mostly related to the ventricular depolarization, sorry, and then the T segment is basically the ventricular repolarization or relaxation. So when we come to talk about the myocardial infarction, we will focus on the ST segment, which is the segment from S to T. Is it depressed altogether, or is it elevated, or is it normal? This is important for us. What else? Here, as you can see, the one I told you about, the ECG abnormalities. So here, This is important. So when we have unstable angina, so the echocardiogram initial findings that we have ST depression or the T wave has inverted. So where is the T wave? This is the T wave. It has been inverted, and the ST it has depressed. But the thing is, there is no markers have been found because we still don't have infarction yet. طيب, when the infarction has been started, we got non-STEMI or STEMI. So this is where you got chest pain, wider radiation than usual angina. The biomarkers it will occur on both of them, but to differentiate between non-STEMI and STEMI, the non-STEMI, which means there is no ST elevation, which means there's ST depression or the T wave inversion. But here in the STEMI, there is ST elevation and later the Q wave. So here you can see here the elevation after the myocardial infarction. So acutely, when the first start, there is an elevation. But after an hours, as you can see, the Q wave, it will start to appear. This is the Q wave. And then the T, it has been inverted after 1 to 2 days. So it's important to know the timing, okay, because you might get a question related to it. So the T wave 1 to 2 days has been inverted and the Q has been going deeper. After days, the ST, it will normalize and the T wave is still inverted, but weeks later, the ST and T is normalized, but the Q wave persists. When you see an ECG of the patient after a prolonged time of infarction, how you can say that basically this is a normal person or a person with myocardial infarction after a few weeks, that the Q wave is still persists, okay? It's still persisting, but the ST has been normalized. Here is the same thing when we talked about, I told you that in stable angina, there is basically no increase in the biomarkers. Is my voice still audible? Or do you have any question? Sorry, I can't see the chat, so can someone open up the mic or say?
Yes, it's clear.
It's clear, thank you. So here, when the unstable angina, we say there is no increase in the biomarkers. In non-STEMI, you can see the biomarker. And the ST elevation, of course, it's present in the STEMI, and vasospastic angina, it's not present. Okay. Now, the cardiac biomarkers, they are basically the endogenous substance, okay, it's been released from the bloodstream when the heart has been damaged or stressed, okay? Those will help us basically to diagnose and to know how to manage this syndrome or this disease. The most common biomarkers, we got troponin, CNI. They have been considered to be a gold standard detecting MAI after 2 weeks. We have high sensitivity and high specificity. They have high sensitivity and high specificity. And we have a creatine kinase. It's not specific. It's also it's present with muscle disease. And we have an AST, which is less specific, determine the size of the infarction. So here, as you can see, how the biomarkers have been formed. So as the onset of the myocardial infarction, the plasma membrane of the necrotic myocyte becomes leaky. This is why those molecules, they can leak out into the bloodstream and they can be assessed or diagnosed. And we will find it in the circulation. So this is important. This is very important. I believe that we have got a question regarding that which biomarkers will appear first. So the first one basically to appear is the myoglobin. It's after 1 or 2 hours. But the highest peak is for the troponin, okay? And also we got the creatine kinase. It also appear after like 4 hours. So you might get hidden of the names, and you have to know, for example, this one is which molecule is this and which molecule is that. So here we have the heat after MI. So how the body will try to close or make an injury, as explained earlier. The unique features of the wound healing is that the cardiac contraction of the non-infarcted myocardium puts a stretch on the wound healing process. So non-death cells, they will contract. This is why they will try to cardium. And the architecture of the infarct is slightly controlled to maintain the cardiac function. Okay, you can read this one. I don't think that you will have a questions related, but just read this part. Now, here this is important. The four phases of wound healing. First of all, we have the death of the cardiomyocytes. After the death, we have the release of the biomarkers, the troponin and the myoglobin, creatine kinase, and then the fatty acid binding, protein and serum glutamate. Okay, and the phase two, we have early inflammatory response to the activation of the complement system. So the body will try to consider it as an inflammatory response. So it will release its cytokines. What are some types of the cytokines? Interleukin 6, interleukin 8, polymorphic neutrophils. It will infiltrate, and then macrophages. It will come. Okay, يعني في عندنا زي inflammatory process it's occurring. Phase 3, the formation of the granule tissue. It will close this infarct, increasing the strength and preventing cardiac rupture and angiogenesis. We have a collagen also intervention. Phase 4, where the scar has been formed, the collagen becomes completely cross-linked and cells as macrophages start to disappear from the tissue. Okay, so I think we'll explain it more in this figure. So as you can see it here in the A, in 1 day old infarct, we have something called wavy fibers. So the fibers, they are not tightened, they are weaky or weak, and edema has been formed as well. And in the B, as you can see, the neutrophil, you will see inflammatory process is going on. Neutrophil has been infiltrated, and after 3 to 4 days. In the C, we have removal of neurotic myocytes by the macrophages, or we call them phagocytosis. The granulation tissue has started to be forming by the aid of the collagen. But it's still not not completed. Here in the A you can see لما يشوفوه it will appear blue under the microscope where the dense collagen scar has been formed. Okay. Here the reversible or irreversible injury. I think this one you have took it with Dr. Wael lecture or Dr. Dalia. So here after half hour or 30 minutes we can say that you can reverse the infarct. Okay, so in the light microscope, you will see no changes, but under the electric microscope, you will see the relaxation of the myofibrils, glycogen loss, and mitochondrial swelling. So the ATP has been depleted. Okay, this is why lactic acid will start to be forming. At the irreversible injury, 30 minutes to 4 hours, the gross features none, as well as in here. At the light microscope, you will see some waviness of fibers at the borders, and here you can see the sarcolemma disruption, mitochondrial amorphous disintegrate. So the mitochondria, it will start to flop or denature. Now, in the 4 to 12 hours, we have like dark mottling in the gross feature. You will see the heart it's being like in a dark botted. Light microscope, early coagulation, there is necrosis, there is an edema, and there is an hemorrhage. 12 to 24 hours, so it's been a day. Also, a dark mottling, and the light microscope, we have necrosis has been started by kinesis of the nuclei, so the nuclei like disrupted. We have early neutrophil, but here where in 1 to 3 days where it's been so clear that there is infiltration of the neutrophil, so focus on this. And the gross, you will see that it's like yellow or tan infarct center. So in gross and light microscope, it's important to know the differences. And here in the 3 to 7 hyperemic border, you will see that basically there is you can distinguish of the dead myofibrils from the normal ones. The phagocytosis, they will come to remove the neutrophils and the dead tissue. 7 to 10 days, you will see there's the yellow tan, soft, like with the thin margin. I think there's a picture in the lecture related to it. And here, the light microscope, there is well-developed phagocytosis of the dead cells. 10 to 14 days, there is red or grade breast infarct. And here the granulation tissue has been formed, and new blood vessels, collagen deposition as well. To 8 weeks, it becomes like white or gray in color, and the collagen also it will increase. Lastly, we got more than 2 months. The scarring has been completed, and the collagen has been dense. Okay. Now, the second or the last learning goals that we got is how to differentiate between the men or women related to myocardial infarction. So the risk factors that the gender in men, it's all it can yani male gender it's a risk factor for having myocardial infarction. For the women, it's diabetes and hormonal dysfunction. We know that the hormones can like a pre-menopausal woman, it's unlike postmenopausal women, because premenopausal it's more safe from having because of the estrogen. It's giving like safety from having the heart disease. The pathophysiology here we got the more fragile vessels or weaky, but stenosis is less. And here the men, the thing about them is they have a chest pain, but here the women is silent infarctions, they are common. So having a chest pain, basically, this is a good sign, because they can know that there is a problem, and they can go to hearing. But for the women, it's hard, because yani, it might be too late for them, because they're not feeling that there is some problem in them. So here are the symptoms of men versus women. And women, we said it's unclear. It's more absent. We call it vaguer symptoms, like nausea and vomiting and dizziness, may not present. Silent infarction, they call it for women. Why? Because we say that they have the infarction 7 to 10 years older when they get their first coronary event. Yani, for example, a man will get it in a 40, the woman will get it, for example, in 50. Just this is the difference, maybe. And also, they get diabetes more often, and this is where it's called a neuropathy. This is the one I explained previously. This is all can lead to a vaguer symptoms, basically. And here, the woman's arteries, I said it's more fragile. It's the pattern of the coronary sclerosis is different, because they have fewer stenosis, more diffuse atherosclerosis. I will show you a picture. This is why it's more likely to cause ischemia, because it's present in more than area, okay? But the rupture of the fibrous cap, this is more in men, because it's concentrated in one area. But here we got the diagnosis. The women have less ST elevation, more ST depression. They got negative T tops or T wave elevation, and non-specific symptoms. The angiopathy resolution sufficient to diffuse atherosclerosis or microvasculars that occur in women. طيب. And here we say that regard the premenopausal and postmenopausal, that there is a difference between premenopausal and postmenopausal. The menopausal increases the risk. It's important to know the difference, 1 to 5 times more for the woman to get cardiovascular disease, the old woman, okay? Because we said that the hormones in the women in the premenopausal can be protective factors. Here, the one that we have differentiated, as you can see, that the men, they basically have generalized, no, this is for the women, most often seen in younger women with ischemic heart disease, generalized narrowing. And as I said, it's a fragile, but here most often seen in men that they have localized stenosis. This is where the fibrous cap can open and the rupture can occur. And also here you can see the cardiovascular disease in men. It's basically increased more than in women. Basically, we have finished the questions, but due to timing, I don't think we have to move to the next case. So here we have 2 questions so that you can practice for yourself. So is there any question? So Dr. Muhammad, you can join.
Thank you.
يعطيك العافية دكتورة سارة.
العافية.
for the explanation. السلام عليكم ورحمة الله وبركاته.